All right, so let's move to the talk. Just a couple of things before beginning. As you heard from Dr. Peckham, CT head and neck angiography has become rampant. We're getting it for all kinds of indications. Had one the other day. Patient swallowed a marshmallow CT angiogram. Right. Another guy, I'm on X or Twitter, and I follow some of these radiologists, and it's interesting from America, and you see them put, just finishing off the on-call shift, last case of the day has to be a CT angiogram, couldn't get away without doing another one. And it's just become out of control. If you're we also do CT perfusion, that has also become rampant as part of the stroke workup. We might do, in a public hospital, we might do 10 cases a day. That's how big it's become. I don't know if you're engaging in this space. I don't know if you're avoiding it as much as possible. I know for me, when CT perfusion came in quite a few years ago now, I was very nervous about doing it because I knew there were, big stakes involved. So I just leave it to the registrar. In fact, because the registrars are guns at it, they do it all the time. In fact, the rumor got around the department that Daniel Saddik had a prostate problem because every time a perfusion came in, I said, I have to go to the restroom. Just be careful that if you are dabbling in it, just beware because there are pitfalls and definite dangers. And can you learn it? Well, I'm a person like that. Absolutely, you can. When I had some time off, I was so nervous about doing it that I thought, look, I've just got to get this under control. Can't have the registrars having something over the consultant. So I looked at 600 perfusion cases. And by then, I felt very comfortable, and then I've gone on to live cases as well. And why would you want to do perfusion and CT angiography? Because in my humble opinion, I think it's one of the most exciting areas in diagnostic radiology going at the moment. I mean, it really is. I mean, I don't know about you. I haven't made a difference to a patient since 1991, but this is something that really you can make a difference to. So interesting. I was asked to give a talk on CT perfusion, and it was almost like an insult in that I was being asked to give the talk because the person said to me, look, we know you didn't know anything about CT perfusion, but you've learnt it moderately well. So can you just give us your tips on it? I said, sure, why not? Okay, so just some general points with CT perfusion. It's part of the investigation in acute stroke. It's combined with CT angiography, and also we add a post-contrast CT brain. Don't over-intellectualize it. You really don't have to. But the one thing you really need to understand is it's a snapshot in time on the background of a relatively fast-moving pathology. So you can have someone, for example, we have someone in the country who has a CT perfusion who might need clot retrieval, but 2 hours later they come to the hospital and that clot may well have moved. Indeed, you can do a CT perfusion, and because of the pumps you're using and slamming a lot of contrast through, you can actually move the clot as well. So that's something to always bear in mind. Perfusion is a little bit controversial. There are some people who say, oh, you don't need it on every patient. But for example, at Monash, we do it on every patient. Our clinicians expect us to. It does aid who gets thrombectomy. That's it. That's the big thing, right? We want to know who to pull the clot out of, as Dr. Mangard will talk about in his lecture. And that's as per the trials. There's level 1 evidence to support that for strokes less than greater than 6 hours. The American Heart Association, the American Stroke Association support it for strokes greater than 6 hours. But for strokes less than 6 hours, it's controversial, but we still do it. There are positive spin-offs as well. The whole study, the CT, CTA, CT angiography, perfusion is very quick, takes about 6 minutes, and it leads to a more satisfactory experience doing perfusion. If I said to the registrars, for example, we're not going to do perfusion on every case, I won't make it out of the car park alive because they really believe it. And it also helps in distal small vessel occlusion detection because the perfusion maps guide you, which I'll show you in a minute. Now, you might say, well, distal small vessel occlusions, who cares? I mean, do we definitely, is there evidence to show that we should anticoagulate those? Is there evidence to show that we should go on and take the clot out? Well, what I would say to you is when you're doing a study, the clinician, especially these clinicians in this field, they expect you to get it right. They're not interested, so what if that doesn't make a difference to outcome or not? They want it done right. Not to mention, there's a lot of engagement in this field in what we call patient-specific therapy. Patient-specific therapy is an American euphemism for when you apply a treatment that there's no good clinical evidence for, but it's still going on. It can also help you to detect TIAs and the stroke mimics, which I'll show you in a minute. So this is out of the Monash group, in fact, and it shows you, just put the laser pointer on, and it shows you here. Now, what they looked at patients with CT angiography in these small vessels, and a lot of patients, they couldn't see the clot, right? But then with the benefit of the perfusion, you actually are guided to where the clot lies. And unless you're doing these all the time, it's very hard to get your eye in. Again, the registrars are guns in it, but I personally would really struggle to see that without the benefit of the perfusion to guide me. Just some brief definitions for perfusion. There's only a few. One is penumbra. It's hyperperfused brain tissue, and it's going on to infarction in the absence of reperfusion. That's it. And then there's core, which is the infarcted brain. Irreversibly damaged, it's dead, it's not coming back. Now, there's a bit of looseness with the definitions, but these are probably the best way to think about it. And then we talk about a mismatch where you have the penumbra minus the core. So that's the three definitions that you must know. The goal in clinical use is to apply thresholds, which I'll come to in a minute, which can inform treatment decision, and the aim is to salvage the penumbra, because obviously we don't want it to go on to core infarct. The perfusion parameters are a way of assessing arterial flow. They are indirect markers of effects on tissue. So that's very important. That's it. So when I say it's a way of assessing arterial flow, anything that affects arterial flow can affect the perfusion parameters. It doesn't matter if it's something pathological. It doesn't matter if it's just a variant in the circle of Willis where you have a larger PCOM on one side than the other. Anything that affects arterial flow can affect the perfusion. And as it's an indirect marker, it should be compared with MRI. MRI, we do diffusion, we see an abnormality, dead brain, move on. That may not be the case with perfusion because it's an indirect marker. Now, we generate all these maps, the MTT, the CBV, the CBF, the TTP, the Tmax. But what they all represent is just temporal characteristics of contrast as it travels from the arterial system through the brain parenchyma. And the two determinants of transit are arterial flow and intrinsic tissue characteristics. And this is the big one. Again, markers of arterial flow. And this is very important to understand, just to say, yes, they're markers of arterial flow because this is where the pitfalls happen and the mistakes happen in perfusion. We use an automated software product. Most centers do. We use Rapid, which quantitates the perfusion maps. It's been used Rapid has actually been used in the major trials, including the Dawn and Diffuse 3 trials. And as the name suggests, it makes things rapid, much easier and quicker. Now, I have to be careful about this. I gave a talk on this and people picked me up on it. They said, oh, you work with one of the people that invented Rapid. You should have mentioned that. I said, so what? It's not like I've got any money. No, I wished I did, but I don't. But I just want to put it out there that I don't have a financial interest in it, even though I do work with somebody who invented Rapid, but unfortunately his brains did not transfer to me. Okay, so with the perfusion parameters, I showed you all those parameters, CBF, CBV, MTT and all. Look, I personally only use two parameters. The CBF, right? And you don't even have to know this definition, right? I don't know anything about the physics. I don't understand anything about it. All you have to know is CBF, and a CBF less than 30% is the marker for core. And that's a core being, remember, dead brain. It's not coming back. And that's been extensively validated in the anterior circulation, but it hasn't been extensively validated in the posterior circulation, although we use it for that. But just be careful. These are markers, CBF less than 30%. It doesn't mean you can't have a core abnormality if the CBF is 40% or 50%. It just makes it much more likely. So we use this as the threshold. And then on the other side, we also use what's called the Tmax, which is the time from arterial peak to the peak of the tissue concentration curve. It measures the delay in arrival of contrast. Again, you don't have to know much about the physics. You just need to know that a Tmax greater than 6 seconds is the best predictor for penumbra. Remember, penumbra is where you have flow, where you have decrease in flow, where if you don't correct it, it's likely to go on to infarction. That's been validated in the anterior circulation only, not the posterior circulation, although again, we use it in the posterior circulation as well. But again, be careful. I mean, these are thresholds. It doesn't mean that if you have a Tmax greater than 4 but less than 6, that can't be a penumbra. It just means that in most cases, a Tmax greater than 6 has been the best predictor for it. So this is how we run. We do a CT non-contrast, we do a CT perfusion, then the CTA, CT brain with contrast, taking about 6 minutes in total. Now, in the report, you have to try and just, before you report it, try to determine the site of the lesion from the clinical details. Good luck with that. You'd be lucky to get the correct name on the report, on the request, let alone clinical details, or you might just get stroke, or you might get left-handed symptoms. So sometimes you get very little clinical details. The referrals are often suboptimal. You don't know where they're coming from. Hopefully they're coming from neurology, but not always. And you've got to understand the referrers, the reason why we do so many of these and so many of them are negative is that the referrers are scared of missing a treatable stroke. You can't blame them. If I said to you, look, there's a patient here, if we do a clot retrieval, not me personally, but if they do a clot retrieval and the patient's going to get extreme benefit from that, you're not going to want to miss out. You're a clinician, you think, could it be, could it not be? I'm not taking the risk. So I'm going to do I'm going to send it along for a CT perfusion. And in fairness to them, look, clinically it may be difficult. But, you know, it's not unusual to just get negative scans. I had one the other day. The clinical history was facial asymmetry. And at the end, I reported it. I said, look, no large vessel occlusion, no perfusion abnormality. Point number 2, patient has lip abscess, which might account for the facial asymmetry. Now, just remember this, that the report is really in 2 stages. That's how you have to think about it. There's the fast stage, because everything's moving very quickly here. The patients are coming in by ambulance. They've already had their CTs been lined up, and the neurointerventionalist may have already looked at the scan before you've even looked at it, right? Everything is moving very quickly. So you have a fast stage and a slow stage. The fast stage, you've got to get to the guts of it and do it quickly. So firstly, CT brain, is there a bleed? If there is a bleed, generally we won't do the perfusion, but we will go on and do the CTA. The text note, you know, are right across this. Bleed, okay, probably no perfusion. They might call us, but they'll definitely do a CTA without even calling us, just straight onto it. Is there an established infarction? You look for on the CT brain, but the CBF is less than 30% is more sensitive, although neurointerventionalists do seem to put a lot of money on the CT brain with regards to infarction. Personally, I look for a dense basilar and MCA sign before I look at the angio, only because I want to keep my skills up in that area, because you never know when you're not going to get the CTA with it, or the history's been a bit deceptive. And other things that can occur. Remember, we're imaging a lot of people who aren't having strokes. They have other phenomena as well. And then I look at the maps, the quantitative maps, and I'll show you examples of these. We start off with the CBF less than 30% and the Tmax greater than 6 seconds. Again, the rapid software is brilliant. It's sorted it all out for you. And then you can look at the other maps where they're dealing with other thresholds. For example, a CBF less than 40% or a Tmax greater than 4 but less than 6 seconds. And that's what we do next, as I've just described. And then I go to the CTA, and the perfusion map should guide you where to look. But I will show you examples where you have to be very, very careful about that. And for me, and I would suggest, especially if you're first starting off, because as I mentioned in mistakes, in the talk I gave on mistakes in radiology yesterday, you have a first, second, and third look at the basilar artery. You do not want to miss that. Every year in every hospital, we've had issues, and it is devastating. Do not miss that. So personally, I go there first. I call through every result. I call through if they're positive, and particularly if they're negative, and I fill the stroke team out, because the stroke team, don't forget, a lot of them are guns on CT perfusion, right? This is not their first rodeo. So I'll ring them up and I'll speak to the neurosurgeon, the neurology registrar. I'll say, oh, look, I'm not seeing much here. Did you guys pick up anything? Nah, not having a stroke. It's just a migraine or something else, or just psychological, nothing to worry about. I mean, you do run the problem that you occasionally come through. There are a few registrars, so you ring them up, you go, oh, you think this patient's having a stroke? Oh, could be. What about a migraine? Could be. What about seizure? Oh, maybe. Yeah, so sort of stuffs you up a bit. So you do have to have a good feel. I'm not saying you treat them as gospel, but I think it's a good way to fill them out as well. And you feel a bit more relaxed, because there are, you know, this is big stakes. This is not joking around here. And you have to understand, you have to tell the referrer, I absolutely believe this, that they need to read the entire report. Because in one of the things that we've missed, the problem with CT perfusion is the neurologists, they don't give a crap about pharynx. They don't care. They wouldn't know what the pharynx is, right? Or all those kind of areas that the CT neck encompasses. It's a very, as the Americans would say, there's a lot of real estate there. And what we found time and time again, the report doesn't get read. And so I had a case the other day. I said, you know, good news and bad news. Good news is they haven't had another stroke, but unfortunately the nodule that was reported on the last CT perfusion was ignored. It's now a metastatic lung cancer. So you really do have to emphasize that to them. And the clinicians themselves will tell you, I had a clinician say to me the other day, I reckon only about 60% of our reports get read. Okay, so just be wary of that. And you might say, oh, well, that's not my problem. Who cares? But, you know, as you know, in medico-legal field, everyone gets sued. So why would you want to, you know, get involved with that if you can avoid it? And then you come to the slow stage where you have you know, the post-contrast CT brain. Just remember that is not the same as a CT angiogram brain, okay? You can absolutely see abnormality on this that you don't appreciate looking at the brain on the CTA study. And what happens is you fall into this, you forget to realize that a post-contrast brain was done as the same, was added to the CTA scan as well. So don't think that they are looking at the parenchyma the same. They are not. And that's one of the additional Ps I've added to the periphery as the 4 Ps of acute stroke imaging, the parenchyma, the pipes, perfusion and penumbra, and also now periphery. All right, enough with the theory. Let's get down to it. So 78-year-old female, these are all real life cases. In fact, a lot of it I've just pulled straight from the database. So the histories are exactly how you've seen them there. So right facial droop, dysphagia at 8 o'clock in the morning, symptoms resolving, history, hypertension, diabetes, question mark CVA, and the CT brain was normal. This is the classic that you like to see. It's nice and easy. So here it is. Here's the rapid maps, Tmax greater than 6. Remember I said Tmax greater than 6 is the best indicator, best validated indicator for penumbra. Penumbra being that if you don't revascularize that, it's where you're lacking blood flow to the brain, and if you don't revascularize or if they don't get better flow through that, they'll go into infarction. And CBF, which is a marker for core, the infarct that's not coming back. So the CBF less than 30%, you can see here, the CBF less than, there's nothing that shows up on here, but there's prolongation of the Tmax in that right MCA division. So there's a mismatch there. And here's the cause for it, right MCA occlusion at the junction of the M1 and M2 vessels. So that's, you know, that's like what we like to see, very straightforward case. But be aware, I know this chart looks a bit crazy, but it's actually not as bad as it seems, that the pitfall list for perfusion is that there are a lot of positive and false negative maps, as you would expect with anything like this. There's quality, post-processing software. I'll show you examples of all of these things. Delay in the arrival of the bolus is very important. Arterial injection, because remember we give venous injection, but occasionally there's a mistake and an arterial injection is done. Head movement, lack of coverage is a big one. And then remember, anything that alters the arterial flow, anything can affect the perfusion maps. And then also in regards to that, vascular dysregulation, such as seizures, migraines, press, and hyperperfusion as well. Because again, I just want to reiterate, we're doing a lot of patients here who may not be having a stroke. They're having an alternate diagnosis. Again, seizure, tumor, migraine, and so forth. There are pitfalls. CBF less than 30%. Again, CBF less than 30% is the core. I keep repeating this I sort of need to repeat it for myself when so I remember it as well. It represents the core, the brain that's not coming back. The problem is in the early stroke, you can overestimate the core, and in the later on, you can underestimate the core with a CBF less than 30%. So here's a patient, 58-year-old, last known well 2.5 hours ago. The CTA, I'll tell you now, showed a right M1 occlusion. Here it is, large matched right MCA territory. Look at that, Tmax greater than 6 seconds. So that's the penumbra. And sure enough, CBS less than 30%. That's the core. So it's a huge matched MCA infarct. They had a DWI and the DWI was negative. And you go, what? How did that happen? And the reason is because we imaged early, and the CBF may plummet early and overestimate the degree of infarction. And it's been written up. It's not that common, but it's called the ghost infarct. Some people say, well, maybe we should, instead of using a CBF threshold of less than 30%, we should use it at less than 20%, but that hasn't really taken hold yet. And it is an importance of the CT non-contrast brain. And I think that's one of the reasons why the neurointerventionalists They love that CT non-contrast brain. They'll go to it and they'll say, look, if there was something really going on here, I know it's early on, but we would expect to see at least something. So beware the ghost. Then on the contradistinction, on the other side of it, right MCA syndrome presentation, last known well more than 8 hours ago. And these are the maps. This is a companion case, but it's showing you here, if you look here, this is a prolongation of the Tmax. This is a penumbra being brain that's at risk. And look at that, 250 mils. And you look at the CBF, less than 30%, and there's almost nothing. So looking at that, you'd say there's a huge mismatch here, huge mismatch. And but then we do look at the CT. Patient's got massive early infarction. The DWI confirmed that. So how do you have a situation like that? Right, I told you, CBF less than 30% represents core. So it should be something like this, because this DWI was done very soon after that. And the reason is because, and here it is here, just showing you again, is that when you do late scanning, collaterals can result in an improved CBF. So that can underestimate the infarct size in late scanning. Again, importance of CT non-contrast brain, you can go to that and say, no, there's a lot of infarction here. But if you're not sure, then just do a DWI. I say to the registrars, look, you've got the keys to the kingdom here. If there's any issue, just do a DWI. You know, it's interesting. We always talk about limited resources. The fact is, I don't believe that. I think we have unlimited resources. We can go on. I know that sounds terrible to say, but you look at how we practice. We practice like we have unlimited resources. And in fact, it's almost like, well, we do. So you can go on, you can get your diffusion and try and determine what's going on. So if you're ever in doubt, firstly, ask somebody who might be more experienced. We're fortunate we have neurointerventionalists, radiologists on call, or just do get on and do an MR. So again, just to emphasize, there are pitfalls with using a CBF less than 30% for core, because it can overestimate the core in early stroke, underestimate the core in late stroke. Now, there is a perfusion parameter requirement. In order to generate the perfusion maps, the software needs to have contrast entering and leaving normal vessels. So you have an arterial input function and a venous output function. Now, again, I don't understand the physics of it, but I do know how to look at the picture. Here it is here. That's the arterial, just right near the anterior communicating arteries, and here just at the torcular of the venous sinuses. All right? But you must make sure that they're in the right place. And this is the kind of map. Now, you will get these maps on your system. These are all available wherever you're reporting CT perfusion. You'll have this on your system. And the arterial input function and the venous output function, they all have to be they have to both be sharply defined, single peak. Usually you want more than 80 Hounsfield units for your arterial input function, and ideally more than 100 units. But you have to make sure you've got them on an artery and a vein and not on a bone or motion. Otherwise, you're going to have problems. Here's a patient here. Now, look at this. This looks like there's a penumbra going on throughout the entire bilateral cerebral hemisphere. So whenever you see that, you've got to be, unless the person's really doing badly, you've got to start to think this is artifactual. There's a little bit of CBF less than 30% there. So how do you approach this case? Well, as I said, you can see here the Tmax map is almost all the brain is involved. I'll tell you now the CT brain and the CT angiogram is normal. So it's unlikely to be completely pathological, of course. It doesn't mean that you can't have pathology superimposed on artifact. Absolutely not. Could it be due to head movement? Could it be due to arterial input function or venous output function, how we've set them up? Well, how do you check these? Well, you can check the graphs, the source perfusion for head movement. That was clear. You can check the placement of the markers. That was acceptable. But when we check the graphs themselves, this is what they should look like. And this is what they look like here. Look, the Hounsfield unit peak is only about 50. It should be at least 80. And that's not a sharp, nice peak there for the venous output. And there are reasons for that. They can include anything. Well, it suggests that there's a poor bolus delivery. So that can include contrast extravasation. It can include the injection rate, poor cardiac output, and proximal carotid stenosis. And in this patient, when they had a look at them, they had lost a lot of contrast in their arm. If you do an inappropriate vessel selection, so that's clearly not on an artery, you can reprocess and you don't have to rescan them again. So I just want to re-emphasize this. Just because you have an abnormality that might look like it's artifactual, it doesn't mean that you can't have clinically significant pathology as well. We've had a few misses like that where they get written off. Oh, doesn't matter, artifact, forget it. But you just have to be wary of that. And you can always use MRI to support. to further investigate. So here's another one, 58-year-old, right facial droop and stroke code. CT non-contrast was normal. The CT angio was negative. All right, this one was missed, unfortunately, because you can see here the Tmax, nothing. There's no perfusion abnormality here, greater than 6 seconds, no problem. Nothing on the CBF reported as no perfusion abnormality. Well, there's not on the basis of a Tmax greater than 6 and CBF less than 30%. But don't forget, we're threshold scanning here. So when we look at the other maps where we talk about Tmax greater than 4, greater than 6, greater than 8, greater than 10, we can see there is a perfusion abnormality here. So strictly speaking, this is not a penumbra because it's a Tmax greater than 4 but less than 6, penumbra being Tmax greater than 6. So you look at this and we look at the CBF, there's nothing on that when we go through all the thresholds. And there is something there on the non-quantitative maps. And in fact, this patient had an acute infarct. So you can still have an acute infarct. It doesn't mean you can't go on and have an infarct, but it is less likely if the penumbra is less than 6 seconds. Sorry, if the Tmax is less than 6 seconds. So it's just something to bear in mind that we're dealing with threshold reporting here. There are no absolutes. All right, 84-year-old. Again, straight from the database, code stroke, sudden onset of altered conscious state, eyes open, not responding, localizing to pain, usually independent at home, onset 3 hours prior to presentation, query stroke. If you follow the theory, more than 3 symptoms and the patient's hysterical, you might not believe there's going to be an abnormality here, but CT non-contrast study, normal. This is the perfusion maps. And you can see here, in what looks like a PCA territory, there's just prolongation of the Tmax, not much, only a small volume of 9 mils. So that was reported as penumbra. Okay, nothing really on the CBF maps. And you look at this on the sub-threshold maps. So the maps greater than 4 but less than 6 seconds. And you can see this blue here. And you can see almost the entire cerebral hemisphere is involved bilaterally. So remember what I said about approaching these kind of cases. Again, the CT angiogram was normal. Well, you know that when you see such diffuse Tmax involvement, it's almost always going to be artifactual. But we did see that it was most pronounced on the Tmax greater than 6 seconds in the right PCA territory. The CBF and the CT angiogram were normal. So in this setting, in addition to the other things you might think about poor cardiac output, vascular dysregulation, or some other thing causing a pitfall. And the follow-up MRI showed no acute infarct. Again, we would say that if we have something where there's a lot of likelihood of artifact, we just say, look, do an MRI if you're still concerned. And we feel we're assured because if the CT angiogram is normal, we know that there's not going to be a clot retrieval required, so we can go on and do the MR with a bit of delay. But can you offer an explanation for that Tmax disproportionately increased in the right PCA territory? Well, the answer is here. If you look at the left PCOM, it looks larger than the right one, right? So the machine, the interpretation, the software interprets it as being lack of flow to that right side, and that's why you get the prolongation of the Tmax. There's nothing pathological here. It's not pathological, but remember, perfusion is dependent on arterial flow. Anything that affects arterial flow can affect the perfusion maps. 66-year-old code stroke, visual loss, CT brain, non-contrast, normal. CT intracranial angiogram, normal. Here's an example. The INRs, every time they give a talk on perfusion, they love this case for some reason, but anyway. And you'll see here there's prolongation of the Tmax. There's nothing on the CBF, so they have a very large mismatched penumbra of 115 mils in the left MCA and also the left ACA territory. So I told you the intracranial angiogram was normal, but just be aware to look elsewhere, especially if you've got ACA and MCA involvement. And this patient had a high-grade stenosis of the left ICA. So the stenosis, obviously, or occlusions can occur either extracranially or intracranially. This was sent to me by my friend. You can see, sent it on WhatsApp. I'm sure people wouldn't like this. Some of the IT guys would say, oh, patient confidentiality, but unless the patient's name is hyperperfusion, you should be okay. And there's straight out, you can see that it's an abnormal Tmax map. It's got blue, it's got green, it's got anything. Anyway, as I said, when you look at something like this, you always think, what's the element of artifact? And I said, what's the AIF, the arterial input function, and the venous output function? And he said, I don't even know what AIF and VOF is. What do you use it for? And then what he included was actually this, and this is actually the, this is looking at head movement. Now, you'll get this on your systems as well, these maps showing you head movement. Now, the Rapid can correct for small head movements, or the software, but not for this. This person's like thrashing around basically. So you're going to get a situation where you're going to get artifact on your maps, head motion. Okay, you can also look at head motion on the source perfusion as well, which I'll talk about in a minute. The source perfusion CT. So 75-year-old, stroke code, vertigo and ataxia, 10 a.m., question mark stroke code in posterior circulation. Here it is, and I'll tell you now, the maps were completely uneventful. Tmax, nothing. CBF, nothing. Easy, right? Perfusion maps are unremarkable. CT angiogram, normal. Stroke doc still concerned, which they often are, and will arrange a diffusion-weighted study, and they've got an acute Vermean infarct. Now, this highlights several issues with CT perfusion. When we do CT perfusion, for most scanners, most of our scanners, for example, at Monash Health, can only do a limited area of scanning for CT perfusion. So you want the top of the brain? Great. You want the bottom of the brain? Great. You want the middle of the brain? Great. But you're not going to get the whole brain for most of the scanners, right? So immediately, if you're using perfusion to guide you where an infarct or the angiographic abnormality is, if they don't include that place on the perfusion, because sometimes clinically you can't tell, and sometimes the techs are making the decision on how much of the, what area they're going to put the perfusion map on. So if you don't include that area, you can be misled. The other thing is small lesions may not be appreciated on CT perfusion, and we also know that there are artifacts in the posterior fossa. Here's one here from Bruce Campbell's team, and you can see these are artifacts up near the bone and the posterior and in the posterior fossa as well. Be very, very careful about posterior fossa, because I've seen patients being called artifact when they had basilar artery thrombosis, and I've seen patients being called disease when they've had nothing there. You have to be careful about that. Here's a companion case, 52-year-old male, severe headache, unconscious collapse, right-sided hemiparesis and nystagmus. This was thought to have a problem. They thought, oh, clinically the problem's probably supratentorial. We'll do a supratentorial perfusion, and it was normal. Unfortunately, this was missed. The perfusion did not cover this area as well, and they had a basilar artery thrombosis, and this patient died, right? This was an absolute classic case for a clot retrieval. No, didn't get there in time, too late, missed. Here's another patient. This is another companion's case, 71-year-old stroke code. Okay, patient initially presents. They have here, this is a nice case on the non-contrast. You can see a dense left M2 branch here, and then on the CT angiogram, it's occluded, easy. Patient goes for clot retrieval, fantastic result. Unfortunately, 3 hours later, they represent. 71-year-old female with left M2 stroke, reduced GCS, post-ECR question mark stroke. And we look at it, and sure enough, it looks good. They've got a bit, they've got, the artery is no longer occluded, all good. Thank you very much. See you later. But this patient, in the meantime, developed a basilar artery thrombosis, which is a bit unlucky, but it is a lesson about these basilar artery thrombosis. They're tricky beasts. You've got to be onto them. That's the first thing you've got to look at. And unfortunately, it wasn't reported, and this patient did not do well. So I've emphasized this again and again, and I promise you, if you're doing this, this is the area where you can really come unstuck. It's a review area on all CT perfusions, as missing it can lead to a catastrophic, or all CT brains actually, as missing it can lead to a catastrophic outcome. Here's another one, a dense basilar artery sign. Remember, it may not come to you as a stroke. It might come to you as unconsciousness or altered GCS. I've asked this question before. What does basilar artery thrombosis, spinal epidural abscess, and thoracic aortic dissection have in common? Well, if you miss it, patients do badly. They do badly quickly, and by the time you get onto it, it's hard to reverse. It's been discussed in the literature. You have to look for it. I personally think first on the CTA. I don't care what the history is. I don't care what the perfusion shows. I don't care where the perfusion targets, and I don't care what the CTA shows elsewhere. That's the first thing I would suggest, especially when you're starting off, to look at first. Another case, 86-year-old, acute onset of left hemiparesis, additional history from registrar. Shortly after, the patient also developed right hemiparesis. The symptoms had partially resolved at the time of reporting. The CT brain, the CT angiogram itself was normal, the perfusion was normal. So what's the abnormality here? It's a little bit of a tricky, it is a tricky case. The registrar, you know, it's interesting, the registrars now are really the elite. They are the elite. They're the best this country's produced, the best other countries have produced. Sometimes you think they should be running the country, not being radiology. They're a bit wasted there. But anyway, one of the registrars straight onto this. Do you see the abnormality here? And he's under pressure. He's on call, and he nailed this exactly. So you can see that there's abnormal soft tissue density. This is his report, actually, which is a credit to him. Abnormal soft tissue density within the anterior epidural space, extending from approximately C2 to C6, raising the possibility of an epidural haematoma. MRI to further evaluate. PS thyroid lesion also noted. I put the PS, he didn't put that in his report. Okay, so obviously you never believe a registrar, and we did the MRI and he was 100% correct. He's actually come back as a consultant now next month. But there you go. And it does, we see this every now and again, and you always have to check the spine for cause of hemiparesis, particularly if you've not found a cause on the perfusion map, CT brain or vessels on the CTA. I have seen a case where a patient had the CTA, there was nothing on it, they missed the epidural hematoma in the spine, the patient was anticoagulated and became paraplegic, which is a real tragedy. Another patient, left-sided weakness and facial droop. Here it is, subarachnoid hemorrhage in the left cerebral hemisphere on non-contrast CT. Remember, not everything we're getting is going to be a stroke. A lot of times we're not going to get that. So convexity subarachnoid hemorrhage. We went through the differential yesterday in mistakes in neuroradiology, some of the things you need to think about. Common ones are trauma, amyloid, RCBS. There are others such as central venous sinus thrombosis, tumor even. And in this patient, have a look at the perfusion map. Perfusion map looks weird. It looks like there's a bit of prolongation of the CBF and prolongation of the Tmax. Yeah, and which is unusual for an infarct. You'd expect the CBF to be down and the Tmax also to be increased, which it is here. So there's an area of mismatch, right, in the left frontoparietal lobe, but you also have to think, you know, if that really doesn't, it's a weird looking infarct, if that's an infarct. And the CT brain showed subarachnoid hemorrhage. There was no arterial abnormality, but there was a venous sinus thrombosis. So remember, you have to look at everything, unfortunately. Be careful, as I showed you in my talk yesterday, when you're talking about venous sinus thrombosis, if you look at it in the CT angio, you can get false positives because the flow just hasn't got there yet. And that's one of the advantages of doing a CT brain post-contrast, because you can review it on that as well. All right. This is a little bit of a weird one. If you haven't seen this before, I hadn't seen this before, but fortunately, when I was reviewing the database, this came up. So I had learnt about it. So this is a weird case. So on the Tmax map, it's an old study, but on the Tmax map, you can see that there's this funny appearance. There's decreased Tmax. Now remember, with ischemia, you'd expect a prolongation of the Tmax. Here, there's a decreased Tmax. And on the CBF map in the posterior fossa, all isolated to the posterior fossa, there's an increased CBF, exactly what you would think of the reverse. In ischemia, here it is here, there's a decreased Tmax and an increased CBF. So the question is, what is doing this? This is very sharply defined, right? A sharply defined abnormality. So I'll tell you now, the CT and the CT angio were negative. So where would you look next? What's the next thing you should look for? Well, I'll tell you, just to make things easier, the AIF and VOF were normal. There's nothing there. But there's something else that you should look for on this. Absolutely. And the answer is you look at the source perfusion. Now, the source perfusion CT, may not be realized by many people that when we do a perfusion CT, we scan the brain 20 times. We do 20 CTs through the brain minimum. All right. Obviously, we're not doing it at high dose because for obvious reasons. But that is routinely provided on your console as well. And the source perfusion is very interesting in this patient because what are you seeing here on this source perfusion? You're seeing that, this is weird. The posterior circulation is filling out, but there's no anterior circulation. But I told you the CT angiogram was normal. So the angiogram later on was normal. So how do you explain that? And the reason is that this was an artery, not a vein injected. And I won't go into why it's the left and not the right arm. And it might relate to, and it can also be related when you're doing these injections to differential power injection rates. But it's just something to bear in mind. I had someone who sent me a case of this 2 weeks ago, and I said, oh yeah, that's just an arterial injection. He thought I was a genius, but he didn't know I'd stuffed up the other case before. That's how I'd known it. But just remember, we do have to be careful of radiation. I'm all for a haircut every now and again, but this is a bit too extreme. So there was a case in America. You can see the slide, you've got it with you, but they had a lot of patients where obviously on a few days or a few weeks, they got a bit out of control. So we obviously want to watch the radiation. And just a few other things. 22-year-old female, left paresthesia, now resolved. Further information from referrer, headaches and photophobia for 1 week. The CT brain, the CTA was normal. You can see on the CT perfusion that there's a problem. There's prolongation of the Tmax on the entire right cerebral hemisphere, crossing vascular territories, I might add. And the diffusion was normal. And then you look on the SWE, and as Dr. Peckham showed as well, showing pathology on SWE, these dilated vessels. So what do you think this is? It's not actually an uncommon scenario. This is migraine. Okay. And the clinicians are pretty good at this. They'll pick it up as well. We don't. Another case, again, we're imaging a whole lot of patients who are not going to be strokes. They'll have alternate diagnoses. 63-year-old male, unresponsive with left hemiparesis and bleeding in mouth. I don't know what that's got to do with it. Anyway, this comes straight from the database. Question mark stroke, question mark varices. The CT brain, CTA negative. So what do you think about this? Even if you don't know about the colors here, you can't, in terms of where they sit, you can see that there's an abnormality of the colors here in this right frontal lobe. And you can see it's crossing vascular territories, ACA, MCA, and it looks a bit weird for ischemia as well. And there are 3 things you have to think about when something is crossing vascular territories on perfusion. 1 is migraine, 2 is what this is, and 3 is hyperperfusion syndrome. And this is, I'll just show you on the diffusion before I tell you. You can see all this gyroform, DWI hyperintensity, and also on the FLAIR imaging. And this is seizures, exactly, seizure-related postictal. Just remember, 79-year-old code stroke, Tmax here. The CBF here is actually prolonged. It's not reduced, but it does show you that we do pick up other diagnoses. This was a GBM. It was very hard to see on the CT angiogram looking at the parenchyma on the CT angiogram. We could barely see it. And I know some centers don't do CT brains post-contrast. I think they're great. I think they do make a difference, not uncommonly. But there you go. And that was just, again, that was a GBM with prolongation of the CBF. Okay, so in terms of medico-legal cases, there are the obvious cases where you've just straight out missed an MCA occlusion or whatever. I must say that's very uncommon because the clinicians are often onto it as well. They're guns at it. And, the neurointerventional radiologists are also keeping an eye out as well. So it's very unusual to miss a medico-legal case. The other issue that have been, as I've said, medico-legal cases is that you are scanning a very large area. It's like CT cervical spine. You scan the neck. When we do a CT lumbar spine, although not all the imaging may be sent, we're doing a lot of the abdomen and pelvis. So you are scanning a very large area, and it's a tragedy. The patients come in for a perfusion and no one does anything about the other thing, or it's not reported. I do say to the registrars, I have a pet hate that you are not allowed to put anything actionable in the body of the report that you don't put in the commentary. If it's actionable, let's just say you see something in the pharynx and you say, well, it could be a pharyngeal tumor or whatever, you have to put that, I'll just follow up, and they put in the body of the report. And also consultants do as well, they put in the body of the report. They have to put it in the commentary. Anything actionable gets put in the commentary. And we have had, and I know it sounds terrible, but we have had at our hospital a lot of clinicians saying, we don't read the body of the report, we only read the conclusion, all right? And you might say, well, I put it there, so I'm in the clear. Well, you're not. because everyone gets sued when something goes bad and pear-shaped. And they'll point the finger at you as well. They'll blame you, or they'll say you didn't call it through. There's also another issue with calling results through or alerting them through other communication modes. Things that you might think are, oh, yes, I don't need to call that through. Somebody's going to see the result, or I don't need to communicate it, but don't bet on it because you're going to get burned. You will get burned. One mentor once said to me when I was much, much younger, in better days, he said to me, he said, if you think you should call something through, then call it through. If it comes to your mind that you should call it through, then call it through. Otherwise, you can, you'll get burned. Obviously, I've harped on this a lot, but I really want to emphasize it. The missed basilar artery thrombosis, either because we didn't cover the area on perfusion, so we didn't think about it, the basilar artery was not closely examined, or we thought the perfusion maps were artifactual. I'm not sure how many people have heard about this case. It comes from Radiology Business. I don't subscribe to this journal, never seen it before, but anyway. Hospital on the hook for $120 million jury verdict, that's American. Still a lot of money in American, Australian, after residents missed signs of stroke on CT. Residents, obviously for us, are registrars. The case dates to November 27, 2018, when medics transported commercial real estate broker William R. Lee to Westchester Medical Centre around 3 a.m, suspecting he had suffered a stroke. Providers performed a CT scan to check for a clot, but there was no board-certified radiologist on site. Instead, on-call residents, registrars, examined the images and overlooked signs of a stroke. 3 hours later, an attending radiologist reviewed the images. So the only thing I got out of that was always blame the registrar, because that's what always happens, consultant rule 101. But the fact is the registrars are better at looking at CT perfusions than the consultants are overall, because they're doing it all the time. They're absolute, they're guns, and they're very clever as well. So I'm going to show you the case now. This was courtesy of Francis Deng. He hasn't highlighted every abnormality. This is the only image I have. And this was reported as by the registrar, a bilateral fetal artery circulation. Now, I'm not putting any blame on anyone, because this is, we've all been there, right? It's always tough. So bilateral fetal artery circulation, but there are several issues with that diagnosis. Firstly, you have to know what a bilateral fetal artery circulation, how is that defined? If you don't use it, if you're using something like fetal artery circulation, you should know what it is. Well, one of the rules about that, bilateral fetal artery circulation, is that the basilar artery should be of small caliber. This basilar artery is not of small caliber. So that's one strike against it. The other thing is, if you can see a vessel on a CT angiogram, you can see the vessel here. It should fill out, right? You shouldn't have an unopacified vessel because it hasn't, because you're thinking, oh, it's a fetal artery circulation. No, it should fill out. If you can see it, it should fill out. So it doesn't. So you have to immediately think this is thrombus. But there's something else here that wasn't marked, which really makes me very nervous. And it's actually a tip I learnt from Winston Chong, who's an interventional neuroradiologist. And he said one of the least variants in the circle of Willis, or the arteries around the circle of Willis, there's one thing that should almost always be there, and that is the superior cerebellar arteries, right? And this left superior cerebellar artery is missing, it's thrombosed. So they're the big issues, right? So you don't want to be in that position. Just again, if you see a vessel, it should contain contrast. You have to know what a bilateral fetal circulation looks like. You shouldn't have a small basilar artery as part of that. And where's the left superior cerebellar artery? You can see the right one, but not the left one. And here's a companion case. This is just an MRA. And you can sort of miss it, right? You look at that, what's the abnormality here? Well, this patient's occluded their left posterior cerebral artery. I say occlusion, but on an MRA, remember, you always have to be mindful that if you haven't given contrast, it can be a high-grade stenosis or occlusion. It doesn't necessarily mean an occlusion. Here's another medico-legal case, 45-year-old female, acute right facial paralysis. Actually, that's the wrong history. Don't worry about it. Oh, sorry, this is another case. So 45-year-old female, acute right facial paralysis, cause of Bell's palsy, CT brain requested, normal study, next day, DWI showed an MCA stroke. So we've had a few cases that have come through where the referral has come with Bell's palsy, just a standard CT brain. And in fact, they've had an MCA occlusion. And there has been talk that and when this came to a sentinel event discussion, the clinician said, you should have done a CT angiogram on that patient and not just a CT brain, even though it wasn't requested. It was a CT brain, which I thought was quite unreasonable. But we have had a few cases where Bell's palsies have been misinterpreted, and apparently they can. And in fact, when the patient's had an MCA stroke. So there has been talk about doing CT angiograms on these patients as well. I mean, why not? We do CT angiogram on everything, so go for it. Here's another case, another medico-legal case. This is a 74-year-old woman with left arm weakness. Quite a straightforward case, you know, match defect. This was a watershed, reported nicely as a watershed infarct, and no cause found, right? But unfortunately, this patient, if you look where that, when it was reviewed, if you look where that catheter is going, it should be sitting in the IJV there, but you can see that it's actually going into the artery. It's in the right common carotid. It's in the right common carotid artery, and they went to the theatre. They pulled it out. Frank thrombus was found. Patient had complications, not just from that, but from other things, and the patient died. So, if you do see an abnormality, you have to do your utmost to try and find out what the cause is, okay? Don't just say, oh, perfusion, and just leave it there. Really try hard to see what the abnormality, if there is an abnormality there. And I'm going to leave it there, but I took this from MRI Online. Unfortunately, I haven't referenced it, but it is something that I thought I would include because I think it's a really good chart, because often when you image a patient, you see a stroke, right? But you don't see a significant vascular abnormality either on the MRA or the CTA head and neck. I really find it frustrating. And you think, well, what else could it be? And I think usually cardiovascular. And I think this shows a nice chart here of some of the other things that you may wish to think about.